So today's topic would be surgically important infections which are involving skin and subcutaneous tissue. So let's move further. Now, what are the types of infection which mainly affects skin and subcutaneous tissue? First, we should know the name. Now, these are Furuncle, Carbuncle, Cellulitis, Erysipelas, Impetigo, and necrotizing fasciitis. Now, most of these we are going to deal in this class. Okay. Now, in the beginning, I want to say at least one line for each of them so that you have clear picture when you move further. Furuncle is also known as boil. You must have heard this term before. Furuncle is also known as boil. That means it is the pus-forming infection of hair follicle or related area. Carbuncle is the when many furuncles will fuse with each other, okay, then carbuncle is formed. When many furuncles are fused with each other, carbuncle is formed. Carbuncle is considered as a very serious type of infection. It is almost synonymous to abscess. Cellulitis, okay, in the morning class also we talked about this. This is a active inflammatory condition or stage of subcutaneous tissue area. Okay, mainly subcutaneous tissue area is involved in cellulitis. Till now, there is no pus formation. In detail, we'll talk later. Erysipelas, okay, Erysipelas and Impetigo both are relatively superficial infection of the skin, but Erysipelas mainly involve, okay, epidermis and superficial part of the dermis as well, and Impetigo is purely, okay, involvement of epidermis only. Epidermis only. Please mute yourself, all of you. And necrotizing fasciitis is a very serious infection. Okay, it mainly involves the muscle and subcutaneous tissues in the thigh area. Okay, this is also known as a flesh-eating disease. We'll talk about that later. Now, abscess, we already talked in detail about abscess in the morning class, and some other infections which are not related only to skin and subcutaneous tissue, but they are important surgical infection. They are tetanus. We are going to learn about tetanus in the upcoming classes. Gas gangrene, we are going to learn, and tuberculosis. Now, tuberculosis you have already learned somewhere else. Okay, so probably we do not want to repeat again. What is the causative organism of gas gangrene, guys? Which organism causes gas gangrene? Yes?
Clostridium perfringens. Clostridium perfringens.
Very good. Clostridium perfringens. Very good. Excellent. Okay, also known as Clostridium whalesi. That is another name. Systemic infection like septicemia and septic shock, we are going to learn under a shock topic. And disseminated intravascular coagulation, we have already learned somewhere else. If opportunity comes, we want to revise again. And different surgical site infection, which are known as wound infection, or when we incise the skin, isn't it? Then sometimes there may be super infection on the site. These are called surgical site infection. Okay, this is just an introductory slide. Now, before I move further, okay, all of you, please pay attention to this picture. Share, please. Now, share. This is the slide, okay, which is describing, this is the schematic diagram actually. This is describing the histology of skin and subcutaneous tissue, not a real histology. This is a schematic picture. Now see there, the outer part is epidermis, okay. This is epidermis up to here. This is called stratum basal of epidermis, or the basement layer, and below then that is the dermis. Okay, dermis is divided into two layer. Okay, papillary dermis and reticular dermis. Papillary is the superficial one, reticular is the deeper one. Then still, okay, inside that is a hypodermis. Okay, or also known as subcutaneous layer. So epidermis is the superficial part of the skin. Okay, deeper part is called dermis, and hypodermis is a subcutaneous layer. Now see this. These are called hair follicle. Okay, these are called hair follicle. These hair follicles, they are originated from the dermis and they come out in the epidermis and outside the skin. This is sebaceous gland. Okay, sebaceous gland. Now, sebaceous gland uh, produces sebum. Sebum is an oily substance. That's why it is written as an oil gland also here. Okay, oily substance is secreted by sebaceous gland. This is the sweat gland. Okay, sweat gland comes out with its own duct. Sweat gland. It produces sweat. And these are the different blood vessels and the fatty cells. Now with this easy type of description, now it will be nice for you to move further. Now let's start the topic proper. What do we mean by furuncle or boil? See here, furuncle, okay, or boil is a perifollicular bacterial infection. Now this follicular is the term for hair follicle, the hair follicle which you just seen in the previous picture. Okay, so it is related to the infection of the hair follicle or perifollicular infection caused by Staphylococcus aureus most commonly. It begins at hair follicle but becomes deeper into the dermis and subcutaneous tissue because the origin of the hair follicle starts from the dermis. Okay, that's why it may go deeper into the dermis. Now, in which type of people these furuncular boils commonly occur? See here, one or two boils may occur in completely healthy individual. Okay, sometimes we also get boil here and there in different parts of the body, around the nose, isn't it, or near the upper lip area, and some other part where there is a lot of hair. But if there are recurrent type of furuncle, or we call this furunculosis, if multiple furuncles are occurring in the same patient, then we suspect immunocompromised condition. Okay, the person who may be having poor hygiene. In elderly people, they are also immunocompromised. Some people who are carrying a lot of staphylococcus in their nose, and the people from hot and tropical climate where they sweat a lot. All of these can be the risk factor for repeated type of furuncle or furunculosis or excessive furunculosis. So these are important points. And if that person is a diabetic patient, okay, especially type 2 diabetes, there is very high risk of furunculosis which is repeated because it is also considered immunocompromised situation. So this is about furuncle, okay, or also known as boil, isn't it? Now, what are the clinical feature of furuncle or boil? Now, see there. In the beginning, there are features of inflammation. Now, you all know the features of inflammation. It may look red, it is painful, it may be hot. These are three important features. Furuncle look like a pimple or small nodule in the beginning, and later on, when there is collection of pus, that pus may point to one particular area, and this is a pus point in that furuncle. After that pus is pointed, treatment would be very easy. Okay, for example, if I pull that hair out because it is connected to the hair follicle, if I pull that hair out, the pus will be drained, and this is the easy treatment of furuncle. But it is a painful procedure, and many of us don't want to do that. But if we do, okay, and if whole pus or complete pus drainage occur, this is the treatment for furuncle. Now, which are the common site where furuncle develop? See there, okay. The neck, axilla, groin, buttock area, and thigh. But it may occur anywhere on the hairy skin because it is associated or attached with the hair follicle. So wherever there are hairy skin, furuncle can occur. Sometimes in multiple furuncle or furunculosis, we say, the individual may experience fever. There may be lymphadenopathy in the regional area, and there may be fatigue. These are called systemic signs or symptom of severe infection. This doesn't occur, okay, or do not occur in one or two furuncle. If severe type of furunculosis occur, then only these things are seen. Look at the picture here. Okay. Let me describe this with the help of pointer. This is a typical furuncle or boil. Okay, boil is a very common layman term, and this is usually caused by Staphylococcus aureus. Now, if furuncle occur in external auditory canal, it is very, very painful. Okay, and this is one of the common site because the skin is tightly adherent. Okay, the skin in external auditory canal is tightly attached or adherent to the perichondrium. Now, what is perichondrium? Yes, anybody?
It's the outermost layer of the cartilage.
Very good, excellent. This is the external or outer layer of cartilage. Okay, just like the outer layer of the bone is called periosteum, outer layer of cartilage is called perichondrium, and that
It consists of the outer fibrous layer and the inner chondrogenic layer.
Exactly. Okay, so that is perichondrium. Now there are lots of nerves, okay, and the blood vessels in that perichondrial layer, definitely. So it is highly innervated by the nerve, and the skin is tightly attached to the perichondrium. So this, okay, area is highly painful if there is furuncle development there. Now see this, another picture. Okay, look at this area. This is a hairy portion. Okay, this is a hairy portion, and look at this area. Already it is a slight rupture has occurred. Probably some amount of pus is already drained, but still it looks erythematous. If I touch, it would be hot also. Okay, and it is painful. So these are the typical features of furuncle. Now, how we do the management? We don't need any investigation in case of furuncle. Okay. Having said that, if there are multiple furuncle in the patient, and if the furuncles are repeated there, for example, many times within 2 to 3 years of life, we want to rule out immunocompromised situation. Just to do a few tests, okay, to rule out immunocompromised condition, rule out diabetes, rule out other immunodeficiency disorder. So this is the way. Now, regarding the management, furunculosis usually respond to simple measures like warm skin compresses and good local hygiene. So warm skin compresses. Okay. So see here. So let me write one other term for this. This is called hot fomentation. Okay, hot fomentation. Now, what do you mean by this? This hot fomentation means application of heat on those furuncle area so that the pus will be pointed, and later on the management will be very easy for us. We can easily express the pus outside, and that's the treatment of furuncle. So hot fomentation or warm skin compresses is one of the very important part of the management. Another one, we can do the dressings with magnesium sulfate paste, which may encourage spontaneous discharge, and that is the treatment for furuncle. Now, resistant cases may require incision and drainage. Okay, just like an abscess, it may require incision and drainage. We have already tried other thing, but if it is resistant, then only we go for this. At the same time, because it is caused by Staph aureus, so we have to prescribe this antibiotic like flucloxacillin, okay, cloxacillin, nafcillin, okay. Methicillin is not usually prescribed for the treatment purpose. Methicillin, okay, is mainly used for the checking whether that bacteria is a methicillin resistant strain or not. Only that for that purpose methicillin is used. Other antibiotics are anti-staphylococcal antibiotics, which are commonly used in the clinical practice. Even erythromycin can be used. Now, For recurrent cases, we have to rule out immunocompromised state. I have already talked about this. Okay, and one more thing we can do, this patient may be having staphylococcal caries on their nose, okay, on their nose. So application of some antibacterial agents may be helpful. Okay, so we can use certain ointment or certain cream which are anti-staphylococcal in nature. Later on we'll talk about them, but right now if you want to know the name, these are called fusidic acid and mupirocin. Fusidic acid and mupirocin, these are highly specific for skin infection. So these can be applied for few days so that the number of staphylococcal caries will be decreased. Okay, now see there, what complication can happen after furuncle? If multiple furuncle, if they coalesce or join with each other or fuse with each other, then they can form carbuncle. Now, carbuncle is considered a very serious infection. And another thing, if this furuncle occur near the upper lip area, okay, let me explain this. Let me take a bit of time here because this is a very important point. In the upper lip area or very near to the nose, okay, then these have connection, the vein which are draining this area, they have connection with the intracranial vein. Remember that they have connection with the intracranial vein through, okay, through emissary vein. I'm giving you a little bit more knowledge here. Through emissary vein, these vein which are draining this area have connection with the intracranial vein through emissary vein. So what does that mean? If I squeeze, okay, or if I press this furuncle which is present there, okay, forcefully, then the infected material can be forced inside through this emissary vein and it may reach into the intracranial vein. Now, one of the important type of intracranial vein is cavernous sinus. Okay, so that cavernous sinus may be infected, which may lead to cavernous sinus thrombosis, and this is a very serious infection. So, what is the lesson you have learned? Never squeeze or never give pressure unnecessarily on the furuncle which is developed in the high risk area. This is called high risk area on our face, that is near the upper lip and external part of the nose. You can also consider lateral aspect of the nose or infraorbital area also in that list. Now, another part of today's lecture is carbuncle. Now, you already know a lot of things about this. The carbuncle, okay, is developed after many furuncle will coalesce or fuse with each other. The literal meaning of carbuncle is charcoal. Okay, this is a literal meaning. It's charcoal. But we do not bother about that literal meaning actually. Okay, this is just a theoretical, importance. But practically, okay, practically, what is important for the medical students or the doctor is how to diagnose the case. What clinical features are important so that I can diagnose it and how I can treat it effectively. These are important ones. Okay, so let's move further. It is an infective gangrene of the skin and subcutaneous tissue. Now, this term is not used commonly everywhere, but this term shows it is a serious infection of skin and subcutaneous tissue. Okay, it is a lethal type of infection there. It is caused by Staphylococcus aureus, and the most common site of occurrence are nape of the neck, back, and lower limbs. So nape of the neck, back, and lower limbs. These are the common site. Remember, these are important MCQ questions for in the exam. Okay, that's why they are highlighted. Now, it is quite common in diabetic individual and after 40 years of age because these diabetic individuals, okay, they are relatively immunocompromised peoples. So if somebody develops serious type of carbuncle, I like to rule out whether that person is diabetic or not. And what test I do to know whether that person is diabetic or not? Which test is that? Yes?
Insulin.
Sugar level.
Exactly, sugar level. You're absolutely right. Okay, this is done by blood sugar level. Okay, see here, that blood sugar level can be fasting blood sugar, okay, or random blood sugar. Fasting blood sugar or random blood sugar. Random blood sugar also can be done a postprandial, means after 2 hours after the meal. One more knowledge, okay, this is the way I teach. Many important related information I want to give together to my students. Another way, how long that person has been a diabetic, and how badly the blood sugar value is there. For that purpose, we can go for HbA1c. Okay, HbA1c. This is called glycosylated hemoglobin. If blood sugar is not properly controlled for the last 3 to 6 months, then this HbA1c value will be higher than the normal. Okay, so these are the two important tests which I want to do to rule out whether this person is diabetic or not. Never forget this. And it is more common in male than in the female. Okay, probably males are more hairy than the female. That may be the reason. Okay, now share. Now let's talk about the pathogenesis or pathophysiology of carbuncle. Okay, how this happens. In the beginning, there's infection. That infection developed into a small vesicle-like structure. Now, vesicle means it is a fluid-filled blister. Fluid-filled blister which is less than 5 millimeter in size. And till now, that fluid is clear. That is called vesicle. Clear fluid-filled blister less than 5 mm in size. Now, what will happen? Okay, multiple vesicles may fuse with each other. Okay, or the single one may progress. Okay, an extensive area in that region may be affected, and it looks like a sieve-like pattern. Okay, it looks like a sieve-like pattern. Sieve-like pattern means there are multiple opening there. Okay, now that area look red, indurated, and discharging pus. Okay, many furuncles like lesion, they fuse with each other. I already talked this many times. The colis are fused with each other, and ultimately it looks like a cribriform plate-like appearance. Okay, or sieve-like appearance. Okay, so this is the hallmark of carbuncle. Okay, and disease may spread rapidly to the adjacent skin. And one thing I like to rule out, make sure this patient is not a diabetic and they are not in ketosis. Okay, now what is ketosis? What do you mean by ketosis?
There is ketone antibodies which are produced from the free fatty acids in the liver, and the breakdown
There
of
are
these
antibodies
antibodies.
in the body tissues, a raised level of ketone bodies.
Okay, both of you are correct. Both of you are correct. Ketotic means there is collection of ketone bodies. Okay, and in type 1 diabetes, there is a high chance of formation of ketone bodies. Ketone bodies are 3. Okay, there are 3 types of ketone bodies. If you want to know the name, I'm going to take the names now. First is acetone. Okay, let me write this for you because these are the important knowledge for you. Okay, there is no hurry actually. The 3 types of ketone bodies are acetone is number 1, acetoacetate is the second one, acetoacetate, and third is beta hydroxybutyrate. Excellent, beta hydroxybutyrate. Okay, here, so these are the 3 important types of ketone bodies. So let me write it here so that you can see it clearly. Acetone, acetoacetate, beta hydroxybutyrate in type 1 diabetes, they are a common occurrence in the patient. Now let's see the picture here. Okay, let's see the picture here, how carbuncle looks like. You see this whole area. Okay, it looks very serious one, very serious area. Okay, this is the carbuncle in the buttock area. Okay, this is a natal cleft. So this is a buttock, and we can see different vesicles here. Okay, different vesicles. Some of the areas are already black in color. This is extensive involvement. So this person must be very serious. And one thing I like to rule out in this person is whether this person is in septicemia and whether this person is diabetic or not. These are the two things. If the person is in septicemia, I'll admit this patient in the hospital and use broad spectrum antibiotic and treat this area. Okay, and rule out diabetes. Now another picture, this is a carbuncle in the nape of the neck. This area is the nape of the neck, or you can say base of the posterior part of the neck. Okay, now look at this area here. This area looks very serious. Okay, already the skin is necrosed there. Okay, already the skin is necrosed. See here. Okay, black discoloration of the skin. That's why the term gangrene of the skin is also used. There are multiple opening. If you can see here, the one opening is here, one is here in this area, another is here. Okay, so multiple openings are there, and extensive swelling in the adjacent region is also seen. So this person should be admitted in the hospital and treated extensively. Okay, so this is the one. Now, what are the other important feature? Okay, in case of carbuncle, there is multiple draining sinuses on the surface of carbuncle, and later on they may complicate into ulcer, and that ulcer heal with scar formation. So there may be extensive scar after the healing of carbuncle, and scar is mature type of granulation tissue. If somebody asks you what is a scar, you can answer like this very confidently: mature type of granulation tissue is called scar. Okay, now other clinical features can be this inflammation or infection can extend in the surrounding area. It may go deeper and cause cellulitis, and some systemic symptom can also be there, like fever, malaise, headache, myalgia, arthralgia. All those can be there. Okay, because this is considered a very serious infection. Now see here. Okay, some other pictures. This is a very good one, and in the many exam I've seen this type of pictures was included in the MCQ question or a clinical type of question. See here, look at this area. Okay, this is the nape of the neck. Okay, multiple lesions are there, and later on, after few days, this lesion will slowly expand very near to this. This lesion will also expand very near to this. So this whole area will be converted into one big lesion, and this is carbuncle. So probably these are multiple furuncle at this stage. Okay, but after few days, most of these lesions will fuse with each other, and definitely carbuncle will be formed. Now see here, this area looks very complicated. Okay, this is another picture. What is the treatment? What is the treatment of carbuncle now? So carbuncle is considered a type of skin abscess. So incision and drainage has to be done. And what type of incision and drainage now? Remember in the morning class we talked about this. The cruciate type of incision is given. Cruciate means cross type of incision. Now why? Because there is extensive damage of the tissue. There is already death of the tissue which has occurred there. It is also known as a particular gangrene of the skin. So all those damage and dead tissue has to be debrided. So I need a big incision. This is called cruciate incision, and we need to de-roof that area so that good type of debridement has to be done. At the same time, antibiotics are started. These are anti-staphylococcal penicillin. Okay, if I will ask you the name, it is very easy. Cloxacillin, okay, flucloxacillin, nafcillin. These are the different example. Even erythromycin or clindamycin can be tried, and in very serious cases, you directly go for vancomycin. You should measure blood glucose to rule out diabetic. So these are some of the important points in the management part. Now, after doing carbuncle, let's talk about cellulitis. Now, this cellulitis was discussed already before as well. So this is a bit like revision for you. Okay. Now see there. Let's start with the meaning of cellulitis first. It is a spreading inflammation of subcutaneous and facial plane, mainly the subcutaneous area and the facial plane. There are fascia which are located in that area. Fascia means, okay, they cover the muscle. So those fascia separate different regions on the deeper part of our body, on the deeper part of the skin. So they are also involved in spreading type of cellulitis. But mainly cellulitis is the infection and inflammation of subcutaneous region. Now, this infection may follow a small scratch or wound or even incision on the skin. So this is the way the infection begin or start. Now, look at the causative agent here. Okay. Now there is no surprise regarding the causative agent. The similar type of bacteria, commonly due to Streptococcus pyogenes and even Staphylococcus aureus and other gram-positive organisms. But cellulitis is mainly caused by Streptococcus pyogenes, which is even more common than Staph aureus now. Regarding cellulitis, now what is another name of Streptococcus pyogen? Which term you want to use?
Group A bacteria.
Okay, group A, beta hemolytic streptococcus. Exactly. Group A, beta hemolytic streptococci. Here, group A, beta hemolytic streptococci. This is the short form. Never forget this. This type of questions are quickly asked to you whenever the term comes. So this is the another term. It is also caused by different gram-negative organisms. Okay, so these are the examples which are given here. Gram-negative organisms like Klebsiella, like Pseudomonas, like E. coli. They are also involved, and they are more commonly involved in hospital-acquired infection because gram-negative organisms are more common as a hospital-acquired infection. Now, what happens if that cellulitis is not detected or is not treated in time? Or what happens in case of complication of cellulitis? These are called sequelae. Now see there, the infection can get localized to form pyogenic abscess. Now I already discussed this. Cellulitis is one stage prior to abscess formation. Till now, abscess has not formed. But if we do not treat this in time, if the patient doesn't go to hospital in time, then it can easily convert into abscess. Another sequelae can be, it can spread to cause bacteremia, okay, bacteremia, septicemia, or even pyemia. It depends. Presence of bacteria in the blood is called bacteremia. Along with those bacteria, if they are actively multiplying, and along with that, sign and symptoms are there, we call it septicemia. And pyemia is the presence of material of pus in the blood itself. Now, sometimes the infection can lead to local gangrene. Now, what is gangrene? Yes? What is gangrene?
Sir, it is the necrosis of the tissue.
Good. So what type of necrosis? You have to add one more term there.
Sir,
Yes.
it is two types,
The
moist
following
and
to
Okay.
dry
Good.
gangrene, moist gangrene.
Good. Good. So see here, the answers are there. Okay. Very good. Okay. I'm quite happy with the batch. Actually, many of the students. Sometimes we can plan some question answer sessions later on. Okay. Don't worry about that. But when I take this type of lectures, I cannot ask all the students. Okay. It will consume a lot of time. So rather than that, I can explain myself so all of the students can hear properly. Okay. That's what I do. Now gangrene means it is ischemic necrosis. It's ischemic necrosis of the tissue. That is a literal meaning of gangrene. Never forget that. Okay. But that ischemic necrosis has to be done, okay, only after the blood supply is lost there. Now we are talking about infection here. So how this infection is connected with loss of blood supply, isn't it? That's the answer you need to search. Now listen carefully. What this infection is doing, it is causing edema there. Okay. It is causing swelling of the tissue. Whenever there is edema or swelling of the tissue, especially in some, or there is rise in pressure in that compartment, that rise in pressure or edema can obstruct the blood flow to the local tissues. As a result of this, the ischemic necrosis of the tissue may happen. Okay, this is one of the common mechanism for local gangrene in case of cellulitis. Another explanation you can give, because of the surrounding infection, there will be thrombosis of the small blood vessels which are supplying the tissues there. If they are thrombosed, then also there will be decreased blood supply there, resulting in gangrene. These are the common mechanism. Now, let's move further. Let's talk about what are the clinical features of cellulitis, how we diagnose cellulitis, how the patient present to the hospital. Fever is quite common here because this is extensive type of inflammation or infection. The signs of toxicities are there, like patient may be having tachycardia or hypotension. Now, tachycardia and hypotension. I'm sure every student know the meaning of these. So what is tachycardia? What is tachycardia? Yes?
increase heart rate.
Increase heart rate
Okay.
to the normal.
More than what? You have to include that term. More than 100. Okay?
More than 100.
Exactly. So don't only say increase in heart rate. Your teacher will want another thing. So say both things together. Increase in heart rate more than 100 beat per minute is called tachycardia. And bradycardia is less than 60 beat per minute.
60.
Exactly, is bradycardia. Now hypertension. What is the definition or meaning of hypertension? Anybody?
The hypertension is low blood pressure, sir, in which there is less than 90 systolic and less than 60 diastolic.
Okay, so I'm getting answer. This is decrease in blood pressure. Every student know this is decrease in blood pressure, but that's not enough. You have to mention what is the limit. And if you only say,
less than 90.
exactly, if you say only systolic less than 90, it would be enough. Okay, diastolic blood pressure is not usually mentioned under the definition of hypertension. So less than systolic blood pressure, 90 millimeter mercury, okay, is called hypertension. So these are the important things for you. Now in cellulitis, swelling is diffuse and spreading in nature, and there will be a lot of pain in the local area. There will be tenderness when I touch that area. It looks very red. This is called erythematous, and it looks shiny because of edema. Okay, it looks shiny. The overlying skin is stretched because of the edema underneath. So this is a shiny appearance. And when I palpate or feel it, it would feel warm. So see there, all the features of inflammations are present. Now, if the person is healthy, probably cellulitis will be localized to one area. And even if it is not treated, it would convert into abscess, and then we can diagnose and treat it. But if the person is immunocompromised, the cellulitis can progress rapidly. Okay, so cellulitis can progress rapidly in case of immunocompromised people. Never forget this term. Now, on the other hand, if we feel the regional lymph node, for example, if cellulitis occurs in the lower limb, the regional lymph nodes are mainly the inguinal group of lymph nodes. So they may be tender and there may be palpable, means they are big in size. And they also shows, okay, it is a type of bacterial infection. Okay, now see here. Okay, so what investigation you like to do in a case of cellulitis? Now, this is mainly a bacterial infection. Group A beta hemolytic streptococci or Streptococcus pyogenes is the most important organism. So we have to go for full blood count or complete blood count. And because this is a bacterial infection, there will be leukocytosis with neutrophilia. A neutrophil count is higher. And there is usually raised ESR if you order the test. Blood cultures are important because this is a serious type of infection. This is not a very ordinary superficial infection. This is deeper and a serious type of infection. So blood culture is usually ordered just to make sure that the same organism which is causing cellulitis grows in the blood culture as well. Another is swab analysis. If there is some exudation, okay, then take a swab from that and send to the microbiology lab and they will give you the report. But we don't wait for the report, okay? We use some empirical antibiotic and later on after the report arrives or comes, if the bacteria which we are suspecting are not there, then we should change the course of antibiotic. Now let's see some of the picture here, okay? So whenever you see this picture, then you realize how serious is the infection. Look at this area. Now this is the lower limb, okay? This is the knee area, okay? This is the foot, here is the ankle. So this is the shin. Anterior aspect of the tibia is called shin. The whole area is erythematous or red. It looks very shiny, okay? And all the features of inflammation can be seen. Now, this is a very, very dangerous area. Why I am using that term is there are lots of plane inside this. There are lots of compartment inside the leg. So if that compartment is highly edematous or if pressure is very high, then blood flow in the distal part of the limbs may be obstructed or blocked. It can result in gangrene. So this is one of the lethal complication of cellulitis. Now another one, it has even reached, okay, it has even reached up to the thigh. Okay, here it has even reached up to the thigh. This is another picture. There is a small pus point which we can see on the surface, but look at the surrounding area. It's extensively swollen and red. Okay, extensively swollen and red. I need to make sure whether this is abscess or cellulitis, and the differentiation is very easy. Whenever you are in confusion, just make this area clean somewhere here, take a sterile syringe and a needle and push that needle inside and try to aspirate something. If pus comes, this is already an abscess, and if nothing comes, probably this is still in a stage of cellulitis. This is the way. So another case, some skin have been already lost from the surface. Now this is a extensive type of cellulitis. Okay, see here the superficial part is already gone. Okay, probably they're sloughed off. Okay, extensive type of cellulitis, and we need to rule out whether this patient is immunocompromised or not. Now this is a cellulitis of the face. Okay, see here there is extensive swelling here. Even the eyelids are swollen. One side of the cheek is swollen. Okay, so this is a type of cellulitis on the face. Now, how to do the management, how we manage the case. Because this is caused by bacterial infection, okay, antibiotics are always necessary. Actually, antibiotics are the most important part of the treatment. So I am underlining these first, antibiotics. Now, which antibiotic is the question? Now remember, which organism is most common in causing cellulitis? Which organism is that?
Staphylococcus aureus.
Okay. Now the commonest organism is actually Streptococcus pyogenes. Streptococcus pyogen, or group A beta hemolytic streptococci, and after that only staphylococci and other organism comes. And we know the antibiotic which is most commonly used for streptococci is penicillin. Still penicillins are very commonly used for streptococcal group of organisms. Okay, penicillins. Now there are different forms of penicillin: penicillin G, penicillin V, amoxicillin, ampicillin. Different forms are there, so you can use any of them. You can even use, exactly, you can even use cephalosporin if those penicillins you believe do not work. Okay, you can safely go for first generation, second or third generation cephalosporin as well. Now another is elevation of limb or part to reduce edema so as to increase the circulation in that particular part of the body. Let me take you example, or give you example, sorry, of the lower limb again. If lower limb is extensively infected, then we elevate that lower limb just to decrease, please mute yourself, guys. Okay. Wait. This is highly disturbing. Okay, so let me mute all of you for the time being. Okay, so what I was saying, or what I was describing, is you elevate that part of the limb which is infected, and then okay, keep it like that for certain duration so that the edema is decreased and the circulation is not hampered in that area or distal to that area. This is an important aspect of the management. So this elevation of the limb. Okay, antibiotics already talked about. Another part of the management would be dressing. Now dressing should be done by glycerin dressing or some type of osmotically active substance is applied there so that it will reduce the edema once again. Glycerin is osmotically active substance, so because of its hygroscopic action, okay, because of it hygroscopic action, it decreases the edema, means it absorbs the moisture from there. That is the meaning of hygroscopic action. Another is bandaging. So these are different steps in the management. Please note one thing, there is nothing called incision and drainage here. Incision and drainage is not done usually in case of cellulitis, but I want to give one exception to you. If you palpate the pulse which is present, okay, for example distal to the affected area. Let me take an example here. If shin is affected and if I palpate dorsalis pedis artery, and if this artery is already feeble or already absent, then during that time I should incise. Okay, I should incise at the leg area. I should give few cut there just to make sure the pressure is released there. Okay, this is not a part of incision and drainage. This is a part of fasciotomy. Fasciotomy is one of the important management if there is excessive pressure development inside those fascial plane. Now what complication, okay, what complication can happen in case of cellulitis? Now see here, I have unmuted you again. So whenever I ask question, you can answer now. Some of the complications can be arthritis in nearby joints in about 6% of the times, rarely septicemia, and even endocarditis, infective endocarditis can occur because of the, that organism may go into the blood, and from that blood it may reach the heart, especially if the heart is already damaged, okay, previously, like a rheumatic heart disease or congenital heart disease, then endocarditis can occur. Now, what is erysipelas? Okay, that is another part of skin infection. Erysipelas. Let's talk about it. The meaning is important here. It is a spreading type of inflammation which mainly involve epidermis and the superficial part of the dermis. So, spreading type of inflammation which mainly involve epidermis and, okay, superficial part of the dermis, and it is again commonly caused by Streptococcus pyogenes, the same bacteria which is commonly causing cellulitis, okay, is the common culprit here as well. Now, whenever it involves superficial part of the dermis, that superficial dermis has some lymphatic channel, it has got some blood vessels and some nerves. So after the involvement of this lymphatic channel, which is known as lymphangitis, okay, now there will be cutaneous lymphatic edema formation. This cutaneous lymphatic edema makes that area swollen. It is quite superficial and it is swollen, so that I can clearly see it from the surface. See there, it is quite elevated from the surface because it is very superficial and it is swollen. And why it is swollen? Because of the involvement of those lymphatic channels, because they are blocked, they are inflamed, they cannot drain the lymph from that area. So lymph is collected there. That is the cause for edema in that region. This is a very important point in erysipelas. Sometimes vesicles may form which ultimately rupture to cause serous discharge from the surface. There is no pus discharge, okay? This is a serous type of discharge. Let's move on. So what are the common site for erysipelas? These are the common site. Orbit, okay? Orbit means where our eyeball is located. Face, even on the scrotum in case of male, and umbilicus in case of infant. Infant means less than 1 year old baby, okay. The umbilicus is the common site of infection in them. So orbit, face, scrotum in male, and umbilicus in infant. These are the common site. And sometimes even the lower limbs are affected, but face is one of the commonest site for erysipelas. And if face and near orbit is affected, it causes severe edema, and sometimes that edema will close the eyelid completely and the person cannot even see, okay. Actually the inner eye is fine, there's no problem. Only thing here is edema of the eyelid. Now, what are the clinical feature and how it is diagnosed? Now, toxemia is always a feature here because this is involving the superficial part of the dermis. It has already involved lymphatics. It has already involved some of the blood vessels. So toxemia features are common. Now, if they ask you what are the features of toxemia, you can confidently say fever, myalgia, arthralgia, headache. These are the features. Fever is a very important one. Rash is fast spreading and blanches on the pressure. Okay, so rash is fast spreading and blanches on the pressure because it is quite a superficial one, so it blanches on the pressure. This rash is sharp margin. This rash is having sharp margin and it is raised from the surface. Because of the edema, it is raised and it has quite sharp margin. This is very important point. Discharge is serous if any, okay. Only in cellulitis or abscess the discharge may be purulent. Now, disease is common mainly in poorly hygienic, debilitated individuals. If the hygiene is poor, then there is a high chance of formation of erysipelas, and debilitated means they are, for example, terminal stage of the disease or terminal stage of the illness, like they are having cancer, okay, and they are near to the death. They are very old people who are admitted in the hospital like that. They are called debilitated individual. Septicemia, localized cutaneous and subcutaneous gangrene are the common complication, and lymphedema of the face and eyelid can occur later due to lymphatic fibrosis, but that is not very common. Lymphatic fibrosis is not very common, okay, only inflammation is more common in this condition. Even in the earlier conditions of inflammation, there will be swelling of the eyelid. So these are some of the clinical features. It is very easy to diagnose when we see the picture. You see here, okay. So look at this picture here. Let me show you. Look at this area here, okay, this area. Now, some of the student definitely that doubt is coming in your mind. It almost looks like cellulitis, isn't it? It almost looks like cellulitis. And how do I differentiate whether this is cellulitis or erysipelas? But there are a few important points which I like to highlight again. Okay, erysipelas is definitely more swollen from the surface. I can clearly see it is elevated from the surface. This is probably the most important point. Second one, it is sharply demarcated. Demarcated means I can clearly feel that involved area, and if I press, this area will be blanched like this. These are the negative points in cellulitis. So this is how we differentiate between them. Now this is the lymphangitis of the leg, okay. Note this is a redness and it is rapidly spreading, and again I'm highlighting the same point. I give a gentle pressure here. If it gets blanched on pressure, probably this is a case of erysipelas. If it doesn't, this is a case of cellulitis. Now the last part, okay, last part is impetigo. This impetigo is considered the superficial most infections of the skin. This is highly contagious superficial skin infection because only superficial part of the epidermis is involved here. The superficial part of the epidermis is involved. So see here. And it is commonly caused by Staphylococcus aureus or Streptococcus pyogenes or both. Now let me clarify you immediately, otherwise we will be confused here. There are two types of impetigo. One is called bullous impetigo, okay, bullous impetigo, and another is called non-bullous impetigo. Let me write it for you. Maybe in the subsequent slide it will come again. Bullous type, okay, and non-bullous type. This bullous type is mainly caused by Staph aureus. Bullous type is caused by Staph aureus, and non-bullous type is caused by streptopyogenes. Streptopyogenes. This is the basic difference, and I'm sure most of the students know what is bulla. Now, bulla is a lesion. Okay, it is a blister. It is larger than 5 millimeter in size, and usually inside that bulla there's something, some content, maybe air, okay, maybe some fluid. So this is bulla. Bulla is a bigger type of vesicle. Now, what are the clinical features of impetigo? Now, there are usually multiple lesions which affect the face or extremity. Face or extremity, these are two common areas. They may be macule, vesicle, bulla, or pustules there. Now, bulla is a bullous type of impetigo, but in other type, there may be macule, there is vesicle or pustule. Now, some of the students may be confused here. What do you mean by macule? What is pustule, and what is vesicle. Though vesicle I have already explained. Now, can anybody tell me what is macule? Anybody?
Sir, macule is an area of skin discoloration, sir.
Good. Okay, you're absolutely correct. This is just a simple discoloration on the skin. That discoloration can be any color. It may be black, it may be white, it may be red, it may be pink, it may be blue, but simple discoloration on the skin which cannot be felt, which is neither depressed nor elevated, and the size of that discoloration is less than 5 millimeter. This is called macule. Vesicle is a small blister which is less than 5 mm, and usually the fluid is clear inside the vesicle. Bulla, I've already told you, it is a bigger in size. Okay, and pustule is a pus-filled vesicle. Inside the vesicle there is clear fluid, but inside the pustule there is pus. The size is same, less than 5 mm. So see there, these are the important or special term in dermatology or skin disorders. Okay, but right now if you know, it will be very helpful for you. Another important point in case of cellulitis, in case of impetigo, is a honey colored or golden crust. Honey colored or golden crust which are gummy in nature, means they are quite sticky there. So the color is honey colored or golden color, and they are quite sticky on the infected area. This is another important point of impetigo. And when we forcefully remove those crust, okay, then red area, the underlying areas are red, okay, they can be seen. Now bulla are more prominent in staphylococcal infections, already talked about. Okay, we don't allow to itch in that area. If itching is done, okay, the infection would spread in the surrounding area, and some other parts of the body can also be infected because of the contamination. So itching should be discouraged in those particular area. This is true especially in children, because children are commonly affected with impetigo. And diagnosis can be done by two ways. One is clinical. You just simply examine that area, and if you see a honey colored crust or golden colored crust there, okay, probably this is a case of impetigo. And another is a part of investigation. You take a swab from the lesion and send it for culture and sensitivity test. And if you get those two organisms, Streptococcus pyogenes and Staphylococcus aureus, you got a diagnosis. Now look at the picture here. Okay, so this is impetigo. Look it very carefully here. See this. If I look at the color of this crust, okay, they are called honey colored crust. Honey colored crust, it is quite prominent here and in these areas also. They are very superficial infection of the epidermis. That's why even in the beginning, if there are some vesicle, okay, some pustule, they can quickly rupture and they can lead to crust formation. So this is the hallmark of, okay, impetigo. Now this is an infant. Okay, this is an infant. This infant is having, see here in this area, there is a clear-cut infection here. There is a bulla I can see. This is called bulla. Okay, and see the nearby area. There's lots of other infections surrounding. So these are quite superficial though. Most of them are already ruptured. Okay, and the color typically looks like honey colored. So these are again different type of impetigo. Now if I ask you what may be the causative agent after looking this picture, what is the answer? What is the causative agent here?
Streptococcus pyogenes.
Okay, now see here. Okay, Now there are two organisms, isn't it, which are common, either Streptococcus pyogenes or Staphylococcus aureus. But the question is, if I see a lesion like this, little bit looking like a bulla, and also there are some bulla which are ruptured, probably Staphylococcus aureus is the causative agent, because this is a bullous type of impetigo. This is a bullous variety. So see that. So these are the questions which will be asked to you if you understand the topic. Okay. Now what is the treatment? What type of treatment you like to give here?
Sir, antibiotics.
Penicillin.
Okay, antibiotic definitely. Okay, so which type of antibiotic? That's my question. Remember, the organism is Staph aureus.
Yes, sir. We can use nepenicillin.
Broad spectrum.
Penicillin. Penicillin.
Good. Okay, Irfan and Junaid, they are answering. Okay, so first you say antibiotic, then you have to take few names of the antibiotic which are specific to Staphylococcus, because this is a bullous type of impetigo. So you can say flucloxacillin, cloxacillin, nafcillin, okay, or you can also go for some other variety. Some local antibiotics can also be tried here, because this is considered not very serious type of infection. Now see there. So what are those topical or local antibiotics which can be tried? Look at the name there. They are topical fusidic acid or mupirocin. Fusidic acid or mupirocin. Please remember this name. These are very helpful for you. Even inside your family, if somebody is having some minor skin infection or disorder, you can safely prescribe this antibiotic. Don't worry about the trade name. Okay, try to remember the pharmacological name, which are those, and we can easily get them from the medical shop. So topical antibiotic therapy like fusidic acid or mupirocins, they are indicated in localized cases without complication. They are very effective therapy, okay, and they have a very few side effects. So both of them are very commonly used in clinical practice. Now, in which case we want to go for systemic therapy. So systemic therapy means either oral antibiotic or injectable antibiotic. Now definitely the answer is, if a case is a bit of serious, okay, if there are multiple lesions, if they are spreading, then we can go for a systemic therapy. It's a very easy answer. And these are the recommended oral antibiotic like flucloxacillin or erythromycin, or even cephalosporin, first generation or second generation can be tried. Okay. At the same time, don't forget to give some patient education like good hand washing technique, and avoid to scratch that particular area. And if the fingernails are long, we counsel them to cut those fingernails. Otherwise, the infection may be spread from one area to the other. So these are some of the important points